part of the International Spine Day arranged on Zoom by Benha University Hospital and the Orthopaedic Department at Benha University Hospital. This day contains a gathering of eminent stars and superstars of orthopedic and spinal surgery all over the world. Professor Masato Tanaka from Japan, Professor Young Hai from China, Dr. Hani Anwar from UK, and Dr. Agava from India. Thank you so much, our beloved professors, for accepting our invitation. It's a great honor for us in Benha Orthopedic Department. We will start with the talk of Professor Masato Tanaka from Japan, from Osaka, Japan. He will start his talk about cervical myelopathy. Thank you so much, sir. May you start, sir, please?
Yes, thank you for having me here. Good afternoon, dear.
Full screen, sir, please.
Benha online spine review course. My name is Tanaka from Okayama University, Japan. First of all, I'd like to thank all of you, especially Professor Erashab, to invite me as an international faculty in this course. Today, I'd like to share our knowledge about cervical myelopathy with you. As you know, Japan is too far away from your country. Egyptian Standard Time now is about 2 p.m., right? The time difference is plus 7 hours from your place in Japan. This means 9 p.m. in Japan now. The situation is like this. From your country to Japan, it's night. That is why I must remind you that I might sleep during my lecture. The distance from your place to Japan is about 10,000 kilometers. This distance is 1.5 times longer than the radius of the Earth. If you look at the flight time, it needs about 12 hours to fly to Japan. If you have a chance to visit Japan, please visit Kyoto. I will show you around. This is the outline of my talk. First, I will mention about pathology and history of cervical myelopathy. Then, diagnosis, strategy. Finally, I'd like to present our new technique. This is your fantastic history. Let me talk about how degenerative changes will occur. With aging, the end plates calcify and vessel loss occurs. The entire disc becomes avascular like this. Then the space between the vertebra, that is disc, narrows, and nerve roots become pinched like this. Finally, the osteophyte or disc may compress spinal cord and cause myelopathy. There are two approaches to treat cervical myelopathy. One is the anterior approach. If you look at the history of anterior approach, Professor Fluad first reported ACDF with a dual bone graft. Then Professor Smith and Robinson reported a horseshoe-type graft with iliac crest. However, with this technique, the union rate is not so high compared with today's result. In 1995, AO group invented cervical locking plate to prevent bone graft backout. To prevent donor site problem, cylindrical cage was introduced in 1997. However, cage sinking is a big issue for this technique. Now, total disc replacement is available all over the world. Even though this procedure, unintended malunion and recurrence are not solved until now. Allograft is another option for bone graft. Disadvantage of allograft are its safety and cost. On the other hand, posterior approach is very popular in Japan because Asian people have a relatively narrow cervical canal. Historically speaking, laminectomy has been a standard technique for posterior decompression. However, there are 3 key problems of this technique. Progression of cervical kyphosis were reported more than 30%. Because of post-laminectomy membrane, long-term results were not satisfactory. And the loss of mass attachment caused post-laminectomy instability. In 1970s, there were several attempts to solve laminectomy problem in Japan. Z-plasty and double-door laminoplasty were first attempts of laminoplasty, but these procedures were technically demanding. Now, in Japan, there are 2 main streams of laminoplasty. French door open with bone, or Kurokawa method, and single door open method, Hirabayashi. Nowadays, there are many modifications of previous 2 techniques, and my favorite one is open door with plates. My policy is the simple is the best. Let's move on to the diagnosis of cervical myelopathy. The first step is, as you know, history taking. The onset of present illness is very important. Sudden onset means HOD is vascular or trauma. Typical diagnosis is spinal cord infarction. Acute onset, this means infection or inflammatory or toxic HOD. Typical diagnosis is pyogenic spondylitis. Subacute onset means autoimmune disease or inflammatory. Typical one is RS5. Chronic onset, there are a lot of chronic onset. Many degenerative, sometimes tumor or metabolic. Typical one is spinal cord tumor. Another important thing is you should diagnose the type of paralysis. Monoplasia means nerve root or nerve plexus injury. Typical diagnosis is cervical disc herniation. Paraplegia usually is a spinal cord injury. Typical one is thoracic OLF, ossification of ligament flab. Diplegia of the arms means usually the central cord syndrome of cervical spine. If you see a paraplegic patient, of course, it's a cerebral region. Quadriplegia is the most common type of cervical spondylotic myelopathy. And pentaplegia means respiratory quadriplegia. The second step is inspection. Drop head syndrome is often seen in the patient with Parkinson's disease. Cock-robin position means atlantoaxial rotatory fixation. Cafeola spot means neurofibromatosis type 1. Low hairline is often seen in the patient with Klippel-Feil syndrome. If you see this kind of intrinsic muscle atrophy in a young patient, this means Okayama disease. The third step is taking physical findings. For myelopathy diagnosis, hyperreflexia is a very important finding. Again, this patient shows hyperreflexia of bilateral arms, and Wartenberg sign and Hoffman sign are also positive. This video shows positive Babinski reflex and positive foot chronos. Scapulohumeral reflex or Smith reflex means upper cervical region. When you hit the scapula, then the patient's shoulder is abductive. This reflex is positive. Provocation test is very useful to check the nerve root compression. This is sparkling test. This is Jackson test. This is Lemaitre sign. If grip and release test is less than 20 times, it's abnormal. This test means you can quantify the patient clumsiness. This video shows trick motion of finger flexion. If you fold the patient's wrist, patient cannot extend their fingers. Trick motion. Finger escape sign is useful to check cervical myelopathy. You should check the adduction of fingers, especially the little finger. Parent test is also important to check the carpal tunnel syndrome, as you know. For level diagnosis, to understand dermatome is very important. Thumb and index finger are innervated by C6 nerve root. To remember myotome is very easy. Shoulder flexion, C5. Elbow flexion, C6. Wrist flexion, C7. And fingers flexion, C8. The fourth step is level diagnosis. This MRI shows C5-6 disc herniation and compressed cervical cord. The injured spinal cord is C5 or C6 or C7. Usually, C5 5-6 region means spinal cord is C7. Spinal nerve root is C6. The last step is to check the severity of myelopathy. Newly classification is based on gait and ambulatory function. For example, grade 3 is gait difficulties prevent employment. Runout classification is mainly for RA patients. Class 3A means objective weakness, long tract sign, and ambulatory. In Japan, we use JOA, Japanese Orthopaedic Association classification. This score is a golden standard. There are categories including upper and lower extremity motor function and sensory function and bladder function as well. Full mark is 17. Take home message of history and diagnosis part is cervical TDR is getting popular all over the world. Laminectomy has several disadvantages. Progression of kyphosis, poor long-term result due to scar formation, post-laminectomy instability. For diagnosis, onset of present illness and type of paralysis are very important. Grip and release test less than 20 times means severe cervical myelopathy. Next topic is strategy of cervical surgery. Let me introduce Japanese guideline for spondylopic myelopathy. Research question is there any clear indication of anterior or posterior approach? If the spinal canal is less than 30 millimeter, laminoplasty is better. If the spinal canal is more than 40 millimeter and 1 or 2 disc level, ACDF is better. If there is a spinal canal stenosis and anterior compression are there, you should choose anterior and posterior. The second question is, does ACDF have a good long-term result? As you know, ACDF has a good long-term result. However, there is sometimes an adjacent segment disease. Revision rate of ACDF is from 9 to 15% in the long follow-up. Next question is, what are the early complications of ACDF? Donor side pain is the most common one. Dysphagia and C5 palsy is a nuisance. Shoulder cirrhosis is more than 3%. Recurrent laryngeal nerve is about 3%. Esophagus injury is very rare, but sometimes it's a fatal complication. To check the degree of severity in myelopathy, JOA score is very useful. If the total score is less than 10 points, it's a candidate for surgery. Indication for ACDF for cortectomy are advanced degeneration, symptomatic or painful herniated disc, cervical instability, trauma, tumor, and opioid. Indication of laminoplasty are multi-level CSM or opioid. Developmental canal stenosis less than 30 millimeter. Good cervical lordosis and no subaxial instability. Contraindication of laminoplasty are more than 30-degree cervical kyphosis, K-line minus OPLL. Large OPLL more than 50 or 60%. From now on, I will show you the video anterior procedure. This is 53 years old, C6-7 cervical disc herniation. After intubation, you see and then check the level first, transverse skin incision, and then divide the platysma like this, and then approach to the disc. This is a self-retaining retractor. Use microscope, distract, and then remove the disc. This is rasp. And then use allograft or autograft. And then put the cage. After that, this screw is to prevent backout. Next video is posterior laminoplasty. Let me show you Hirabayashi single draw open method. Step 1 is exposure. Dissect trapezius, splenius capitis and cervix, then semispinalis. Step 2 is removal of spinal process. Then make 2 gutters just medial of facet joint. Finally, open the lamina like a door. 62 years old man, cervical myelopathy due to OPLL. MRI shows severe spinal cord compression. Radiogram indicate K-line minus. After the exposure, make 2 gutters just medial of the facet joint like this. Use steel bar first, then diamond bar not to injure the dura. If you make this gutter too medial, you cannot decompress spinal cord efficiently. If you make gutter too lateral, there is a risk of nerve root injury or muscle bleeding. After open the lamina, you should use a plate to prevent laminar closure. This is postoperative radiograms. One of the problems of this method is laminar closure. Without plates, laminar closure was observed in 34% of patients. Average 10% decrease in AP diameter and opening angle. Results of laminoplasty is very good. They don't have to wear a cervical para. There are several complications of this technique. The most common one is cephal palsy. Epidural hematoma is less than 1%, and nerve root injury is very rare. Anterior surgery for cervical OPLL has some advantages and disadvantages as well. You can perform direct decompression and maintain cervical lordosis. However, this technique is technically demanding, high complication rate. It's impossible to decompress above C2 level. As I mentioned, more than 50% of canal occupying ratio is a good indication for anterior approach. If you choose laminoplasty, you cannot get a good result. According to these papers, incidence of dural ossification is from 13 to 15%. It's not so low. If the dura is also ossified, to remove this ossification is a risk of dural tear. Double layer means OPLL and ossified dura. If this sign is positive, more than 50% risk of CSF leakage after complete removal of ossification. That is why anterior floating method is popular if double layer sign is positive. First, setting of the OPLL, then cut upper and lower margins. Finally, release the lateral gutter like these failures. Esophageal injury is sometimes a fatal complication. For this case, we perform bowel graft to save the patient's life. One of the controversial issues is a strategy for kyphotic or large OPLL. There are two options, laminectomy and posterior fusion, or anterior decompression. There is a famous paper, laminoplasty versus laminectomy plus fusion. According to this paper, there is no evidence to support laminoplasty over laminectomy and fusion in the treatment of multi-level CSM. Posterior in situ fusion with instrumentation. According to this paper, there are a lot of C5 palsy. That's why I don't recommend this technique. Another option is posterior column shortening. This means PSO. But as you know, PSO is very dangerous. Estimated blood loss is more than 1 liter. All time, more than 4 hours. Complication rate is more than 30%. Too much risk. That is why I recommend anterior column lengthening and posterior fusion. This is the most safest and effective method. -years-old female cervical kyphosis case. As I mentioned, after laminoplasty, 4 years later, there is cervical kyphosis like this. For this case, we perform anterior or posterior fusion like this. Final topic is state-of-the-art surgeries. This is the state-of-the-art architecture in BC 2560s. As you know, now MIS technique is a trend of spinal surgery. There are a lot of advantages
However, it also has several disadvantages as well. The problem of MIS fusion is percutaneous pedicle screw misplacement, more than 15%. Radiation exposure and guide wire problem is a big issue for us.
Let me explain the radiation exposure. We orthopedic surgeons had 5 times cancer risk compared with other doctors. I am a MI spine surgeon. I have a 10 times radiation risk.
Maybe you remember this Chernobyl disaster in Russia. Many people died because of thyroid cancer. That is why we like to use CN as less as possible. Now, spinal navigation system is available all over the world. Let me explain the concept of spinal navigation system. If you compare this with a car navigation system, satellite is CCD camera, a car is a surgical tool, and the earth is a patient. When you move the surgical tool, in the monitor, you can see the instrument. For this technique, you need a full carbon table like this. We also have a braking Jackson table like this. It is very useful for navigation. We also have a third generation navigation. Let me show you one case, 16 years old female, horizontal fracture. First, you should get the CAT scan by CN, and then use navigation. But you can understand the image is not so clear. Now I'm putting the guide wire and then screw. This is a post-op. Now we have an integrated OR system. The new one, CD scan is less than 1 minute, like this. We should think about radiation exposure seriously. You can get a full body scan. This case is C2 metastatic lung cancer case. Now you can see the tumor in the odonto. If you look at the CAT scan, there are big osteolytic region there. We perform cervical percutaneous pedicle screw fixation. Let me show you the video. Very small skin lesion lateral to the midline of the neck. Now I'm using the pedicle probe and navigated tap and screw. These are the postoperative radiogram. This is a 5-year-old male atlantoaxial subluxation case due to Down syndrome. Now you can see os odontal there, and then severe compression at C12 level. Let me show you the video. First, you expose posterior part, cut every muscle, and then use navigation. Very small pedicle are there.
drill, measure the length, and then put the screw. And then Shiva lateral mass screw is also you can navigate. Now I'm putting Boyer type screw. After the qualification, now we are putting the rod. This is a postoperative X-rays and CAT scans. This is another case. Breast cancer, multiple bone metastasis case. Now I'm aiming intentionally a little bit medial of the pedicle and then use navigated pedicle probe. You should pay attention not to violate VA. This is a postoperative X-rays. These are the postoperative CAT scan. Now you can see all pedicle screws are inserted correctly. We published this kind of new technique, serum-free biceps, minimally invasive cervical pedicle screw fixation technique. As you know, there are cervical lordosis. This enables us a very small skin incision. If you use this technique, you can reduce over time blood loss and also screw misplacement. This case is a 6-year-old female Kyphotic syndrome. Now you can see very severe cervical scoliosis. If you look at the CAT scan, it's very complicated. We perform surgery for this patient. We remove T2 hemivertebra and put the pedicle screw. This is right C7 radiculopathy case. Now you can see the right C7 nerve root is compressed by osteophyte. For this patient, we perform endoscopic key for craniotomy. First step is make a key four with high-speed bar like this. And then now you can see the ligamentum fragment. Remove the ligamentum fragment with Kelson longitudinal. Now you can see the dura. This is an ultrasonic bone cutter. And then now you can see the nerve root. So osteophyte is also removed by the ultrasonic bone cutter. Nerve root is completely decompressed. This is a post-operative CD scan. Now you can see the previous osteophyte was removed completely. This is another case, 82 years old female, cervical OBLL with kyphosis. This patient is not a candidate for posterior approach because K-line is minus. If you look at CAT scan, you can see double layer sign. This means ossification of dura. MRI shows severe compression of spinal cord. For this patient, we perform navigated anterior cortectomy and floating technique. Now I'm using the high skipper, then navigated pointer. This is an ultrasonic bone cutter. Release the peripheral bone, and then now you can see that this bone island is floating. This is a post-operative X-rays. This is CAT scan. JOA score was recovered. The position of reference frame for anterior approach is very, very important. Usually, there is no reliable structure suitable for reference frame around the anterior neck. If you put the reference frame to the operation table or the head clamp, is too far and it's also mobile. It's not suitable. Our new reference frame adapter is very useful for anterior approach, very close to the surgical field and minimizing intersegmental movement. That's why we can get high accuracy of spinal navigation.
We already published this technique in a European journal as an intraoperative O-arm navigation guided anterior cervical cortectomy. This is an upper thoracic OPL case. You can see a large OPL is compressing spinal cord. You cannot decompress spinal cord from posterior, and you cannot decompress from anterior because of the large vessels and chest cavity. Before surgery, this patient was wheelchair bound. For this case, we perform new technique of posterior decompression of OPLL. Cut the intercostal nerve and then elevate the spinal cord gently, make OPLL floating from posterior. With the navigation, we make 2 gutters from posterior very safely and make OPLL floating like this CT scan. This patient got a full recovery. Another utility of OR and navigation system are biopsy. This is a L5 osteosarcoma biopsy. This is a bone resection of osteoid osteoma. You can perform very small skin incision to remove this kind of tumor. Take-home message for posterior procedure. Good indications of for CSM, cervical kyphosis less than 13 degrees. For OPLL, K-line plus or small OPLL, occupation ratio less than 60%. Complication of posterior approach is C5 palsy, epidural hematoma, and axial pain. Myself's minimally invasive cervical pedicle screw technique is less VA injury, less blood loss, and less OR time. Take-home message
of anterior approach. Good indication, wide canal and less than 2 level region. K-line should be minus and more than 6% occupying ratio of BLL. Complications are donor side pain, dysphagia, and recurrent laryngeal nerve palsy. Navigational surgery for anterior approach is now available. Thank you for your attention.
Thank you so much, Professor Masato Tanaka, for this very informative, very illustrative, and quite valuable talk. Thank you so much, sir.
Thank you.
Professor Ashraf Ismail will be the moderator of this talk, waiting for any questions to Professor Masato Tanaka. Professor Ashraf with us?
Yes. Thank you, Professor Tanaka, for your this very nice and informative talk and deep.
Yes, it's my pleasure.
Some questions. You depend on the most of your cases for the posterior instrumentation of the cervical spine. You attack by transpedicular screws and not the lateral mass screws. I think the pedicular screws are more more stable and stronger than the lateral mass screws. Okay, this one. Do you use the neuromonitoring in your cases?
Thank you for your question. Neuromonitoring, every case we do the neuromonitoring. In Japan, cervical pedicle screw, as you know, the Professor Abumi invented this screw. That's why this technique is very popular in Japan. Now, FDA in the United States also approved this technique. But as you know, this technique is very difficult. Without navigation, I don't want to recommend to do this. Some case, of course, we do lateral mass screw, very easy. But for generative, or if you need strong anchor, the cervical pedicle screw is very strong anchor. Thank you for your question.
Another question said that about the what is the explanation of that frequent C5?
I'm sorry, it's a bad connection.
May you raise your voice, please, Professor Ashraf?
Okay. What about the frequency of C and the explanation both in anterior approach and posterior approach?
I'm sorry, say that again? Because of the bad connection. Somehow,
Yes.
okay,
Yes.
could you?
What is the explanation of the C5 palsy in both the anterior and posterior approach?
As you know, for posterior, the tethering of the C5 nerve, it's the center of the moving, so the posterior. And also, even though you perform anterior approach, so there are a lot of papers, but maybe some maybe reperfusion effect to the spinal cord or other effect. Some cases, maybe you injure the nerve root directly, but I'm not sure about the etiology of the anterior, but there are a lot of papers. Thank you.
What about the robotic surgery and the augmented reality surgery?
I'm sorry, in Japan, so nobody uses robotic surgery. It's very expensive. But in Japan, the UK, I have seen that one, but the cost, if you look at the cost effectiveness, it's not worth it, I believe. Just for now. And virtual, augmented reality or virtual reality, it's not still, we are working on it, but not still in clinical use. Thank you.
This is as okay. Thank you, Professor Tanaka.
Thank you.
Okay. Dr. Ashab, Professor Ashab.
Any other questions, Dr. Ashraf?
Yeah, this is Dr. Raghav from Hyderabad. How are you?
How are you? How are you, sir?
Nice to see you.
Professor
I
Raghav.
was listening to your talk. It's very nice and very informative as usual.
Thank you.
Now we have a little experience with robot here in Hyderabad, which I'll show in my talk. It is it's got a very steep learning curve. Very steep learning curve.
Oh.
I think you need to do about 100, 200 cases before you get the hang of it. The that says 25, but what I would do in 2 hours, it takes 6 hours to do on the robot for a few.
I'm afraid if the robotic surgery become very popular, we might lose our job.
That is one thing. And in cervical spine, especially, there is a significant movement when we are using the robot. So it's very, very tricky there in the cervical spine. I think thoracic and lumbar is okay. But we started and we almost gave up. We almost gave up.
Yes.
Yeah. Lovely. Nice hearing to your talk.
Thank you.
Thank you so much, Professor Masato Tanaka, for this very interesting talk.
Thank you.
Hoping to see you, sir, again, and wishing you all the best, sir.
Yes.
Thank you so much, sir. Now it's time to move